wait, maybe it's me. So Dr. Coury is our last speaker before lunch, no pressure. But just hang in there for half an hour more, and then you can eat lunch. And then right after lunch, I am going to announce the scholarship winners. I was waiting for all of them to attend. And then we'll get busy on more raffle types. But without further ado, I am going to introduce Dr. Coury, and he's going to talk more about pain management. I'm going to plug this in to talk about himself while I plug this in and get him ready for his question.
All right, thank you. So I follow burnout and I'm before lunch, which means if I don't hit it out of the park, I'm never going to be invited back. Thank you for inviting me. I see some folks that I recognize. Is Phyllis Click? Is that, hi? Is Bill Nunez here? Bill? Hey, Bill. It's like a family reunion, like all the warmth and all the awkwardness at the same time. So I've given this talk, this is my third time giving the talk. The first one, I was given an hour-and-a-half slot. The second one was the same talk, and I was given an hour slot. And now I have a half an hour. So here's what we're gonna do. We're gonna ditch the slides. They'll be up, and if I get stuck, then I can reference them. But we're just gonna improv this thing and see where it goes. And if it's terrible and you don't invite me back, no hard feelings, but if it works, it'll work well. So my name is Tom Coury. I'm a physiatrist by training. That's physical medicine rehabilitation. I also have a fellowship in pain management. So, it's okay, I don't care. So you have the slide, you should have the slides. You can review them later.
I'll have Jonathan.
Okay, yeah, all right. So we're gonna hit 5 points, and that's it. And I'm gonna give you the 5 points right away, and then if you wanna tune out for the rest of the talk, you can do that. So the first one is very important. Pain management does not equal opioids plus injections. We need to stop that right now. And that goes for primary care all the way up through the folks that are in my office, including myself. Pain management is not opioids plus injections. And the default position for the patient that you see over and over again for follow-up is, here's your medication refills, maybe do some trigger points, see you in a month. And that gets people into big, big trouble. There was a physician years ago who was doing that. Notes were copy-paste. She lost her license and everything. Okay? And she thought she was doing good medicine. She was practicing medicine. She was evaluating the patient. Notes were copy-paste. She didn't offer the patient anything other than opioids plus injections. And on those two bases, she lost everything. So don't do that. Okay? Second point is there is a difference between pain and nociception. And I'm going to get into that a little bit later. The difference between pain and nociception. The third point I want to talk about are the 3 pillars for pain management. We're going to go into it, but the 3 pillars for pain management are identifying the pain generator, physical health, and mental health. And if you don't address all 3, you can forget about getting your patients out of pain. So pain generator, physical health, mental health. I'll get to that. The fourth one is the F word. What's the F word in pain management? Fibromyalgia? We'll talk about that one. Okay? And then the fifth one is going to be emerging technologies. Kind of what's in our tool bag, what are some cool stuff that's coming out that we can help our patients in chronic. So let me start with the idea that opioids plus injections equals pain management. Everyone defaults to this. I don't even need to ask you. Every single person in this room has had a patient where you've seen them for follow-up and all you can offer them is an opioid prescription and a follow-up in 4 weeks. There needs to be an initiation that every single visit you're trying something new, trying something different. And maybe all that is convincing them to walk one neighbor's house and back before the next visit every day. Or maybe it's a little bit of a stretch that they can do every day. Maybe, and don't be afraid to prescribe therapeutic exercise for patients, okay? What they can do within their capability. It might be sub-maximal exercise. They're not gonna go out and run marathons. That's okay. Every patient is an athlete in their own capability and in their own space, okay? That ICU patient who can barely move, they're still an athlete. Their cardiovascular system is being taxed. just like the person who's on mile 23 of the marathon. So everyone within their space has to be moving, has to be functional. There are 0 diagnoses that I'm aware of, other than like critical care, where bed rest makes a patient better. And that's none. That's not muscular dystrophy, that's not chronic fatigue syndrome, none. There's no diagnosis, chronic diagnosis, that functionally makes a person better by giving them bed rest. So encourage patients to make sure it's not just opioid prescription, see you in a month, opioid prescription, see you in a month. You're not doing them any favors, and you're not doing yourself any favors, and your license any favors either. Okay, next one, pain versus nociception. And this is a good one, because this is something that I have developed over time, and I'm going to share it with you. There is a difference between pain and nociception. They are related to one another. They are not the same thing. I'm going to go back to my space, which is physiatry, and I'll give you 2 diagnostic examples to make this point clear. So imagine a patient who has been paralyzed from the waist down. They have no sensation from the waist down. If you drop something on that person's foot, a nerve fiber is going to fire. That nerve fiber is going to travel up the leg, and it's going to synapse with the spinal cord. That is not pain. That's nociception. That connection is then it's going to try to go up to the brain, but it's stuck because there's a spinal cord injury. So what does the patient experience? They don't experience pain, but they experience something called dysautonomia or autonomic dysreflexia, and it's a dangerous situation. Their blood pressure can go sky high, their heart rate can go sky high, they can start sweating, and can actually be a dangerous situation. So what they'll feel is their autonomic system going crazy, but they won't feel the pain. That's nociception without pain. Now imagine someone who's had traumatic amputation of a gangrenous foot. Now they have phantom limb syndrome. They have pain without nociception. The central processing for the brain and spinal cord from having had a traumatic experience of that foot through all of their medical care has now imprinted on their brain, in the homunculus of the brain where the foot is, pain. And so they still feel severe, real pain in a foot that's no longer there. We need to get away from this idea of what is psychological and what is physical. All pain is psychological. All of it. It's always psychological, because it's being perceived in the brain. Pain is a perception, it's an emotion, it's an experience, and it is influenced by everything that's happened to you from the moment you're born. So childhood trauma experiences, divorces, financial disorders, all of these things add up so that when you do experience a car accident when you're 35, 45, 55, and you had that back injury or you had that leg issue, your brain has now been imprinted on how to process pain. So pain is an experience. Nociception is a physiologic process that takes us to that. This is why, for example, stress increases pain. A bad night's sleep increases pain. Marital strife increases pain. A bankruptcy increases pain. Because the psychological stressors and the nociceptive inputs to the thalamus go through the very same nucleus. There's not a distinction between the two. It's the same thing. So psychological pain is physical pain. They're one and the same. It's always that. And I can say, even as someone who likes to consider myself an athlete, when I'm injured, there's a psychological process that occurs when I have to shut down exercise. So that goes for everybody. Okay. So that's pain versus nociception. I'll give you a little short example if I have, I've got time. So I had a patient who came in who was an older spinal cord injury patient who had recovered when he was young, and he was working as an accountant. He then, unfortunately, sustained a new injury when he was in a motor vehicle collision, and he had a burst fracture of L5. He was on the rehabilitation unit, and they could not get his blood pressure and his heart rate to come down. He was in dysautonomia, or autonomic dysreflexia. No one knew what to do with him. No surgeon was going to operate on someone who was insensate at L5. Why would you operate on an area that's not painful? But this guy was an accountant, and if he sat up, his blood pressure would shoot to a systolic of 220. That's not safe. He had to be supine just to be able to live. So when I looked at the MRI, I thought, I've got this tool in my tool bag called kyphoplasty. What if I try to fix this person's fracture? So I consented him. I'm about to go into an area that's totally insensate, high risk for infection, but we did it. We did a kyphoplasty for him at L5, not for pain, but for nociception. And he did well. He can now sit up, he can now work. I give him an epidural steroid injection at that level every 3 or 4 months to keep the nociception down, and he's totally insensate in that area. He can't feel the needle go in. So that's the distinction between the two. All right, number 3, I remember. 3 pillars of pain. The 3 pillars of pain. So, pain generator, physical activity, and then mental health. So there is something called the pain generator. Nociception contributes to the chronic pain situation. If you have a herniated disc and it's hitting a nerve and it's going down the leg, that's going to hurt. It's going to be painful if you're cognitive of it. So we do want to treat the pain generator. And that pain generator could be a nerve, could be a muscle, could be a disc, could be chronic arthritis in the joints. So you want to address the pain generator. That can be systemic, that can be local. So giving anti-inflammatories orally, an injectable of an anti-inflammatory, nerve pain medications if it's a nerve issue. There's a whole gamut of medicines you can give that are ancillary and in addition to anything that might be opioid. So you think about, okay, what does this patient need? Do they have a nerve issue? Do they have an inflammatory issue? Are they just tight and they need stretching? Do they need therapeutic exercise? What do they need to try to reduce the pain generator? But that's step 1. And in my space, 33% out of 100 is a failing grade. You're not going to pass. Step 2 is physical. When you hurt, it hurts to move. So you don't move as much. When you don't move as much, the forces across the joints go up. When the forces across the joints go up, pain goes up. When pain goes up, you don't want to move as much. So you don't move as much. So you get weaker. And you cycle the brain. The forces across the spine that it takes to collapse the human spine is only about 35 pounds of force. Our spines are not what hold us up. Our discs are not what hold us up. Our muscles are what hold us up. So the more that patient is inactive because they're in pain, the weaker the muscles are going to be. And the weaker those muscles are, the more forces across that spine and the more pain they're going to be in. So no matter what you do, up to and including a fusion in the back, if you are not including therapeutic exercise in the prescription, you're just doing a Band-Aid. And that's across the board. That's an oral medicine, that's an injection, that's counseling, that's physical therapy, that's traction, acupuncture, hanging upside down, manipulation, even surgery is a Band-Aid. What you're doing is you're opening up a window for them to heal themselves. So you give them a little bit of relief, whatever it is. You open up that window, you add a little bit of therapeutic exercise, and you slowly take them out of that vicious cycle of chronic pain. Not I can't, I can. I can do this, I can do this, I can do this. So many patients say, well, when I was younger, I was an athlete and I could do all these things and now I can't do any of it. You say, yeah, that's right, you can't. But you can do something. And something more than nothing. So that one little bit of a walk you can do today. That one little bit of a lift that you can do today. And then work alongside your physical therapist if you're nervous about that. If you're not sure what's safe, then that's okay. Work together alongside your physical therapist to figure out what game plan would work for those patients. That's totally fine. So that's therapy, or that's physical exercise. That's 67%. That's still a failing grade. That doesn't pass. Your patient's not going to be out of pain. A chronic pain patient, for 30 years of chronic pain, if I snap my fingers and I make their core strong and their herniated disc go away, they will still be in pain. because there's been an imprint at the level of the brain. That's the phantom limb issue. That's the kid, and I got one right now, that's being told by his teachers, you're the bad kid, you're the bad kid, you're the bad kid. So guess what that kid's going to grow up to be? He's going to grow up to be the bad kid if he doesn't stop. Your pain to the brain is the same way. You're in pain, you're in pain, you're in pain, you're in pain. You take away that area, your brain's still going, you're in pain. It's the check engine light on your car. When you fixed it, okay, the fix is done, but that light, that code is still firing and that light's still on. So that needs to be addressed too. That could just be reassurance, that could be counseling, that could be in the office, or the next layer, which is actual psychological help, whether that be counseling, trauma therapy, which is a huge component of this, chronic pain therapy, which is its own unique subspecialty of counseling, could be medication, and then all the other stuff that was talked about in the labs, having your patient give themselves a break, having those stress relievers, going for walks, doing all of those types of things are important too. So now, if you address their pain generator, the physical health, and the mental health, now you have a leg to stand on. Now you have an opportunity to actually get a chronic patient out of chronic pain. But if all you do is address one or two of them and ignore the other, you're not going to make it. Okay? If you treat their chronic pain as all physical, you're wrong. If you treat their chronic pain as all mental, you're wrong. It's both and at the same time, at all times. Okay, so now we lead to the F word, fibromyalgia. So what is fibromyalgia? Everyone has their opinions on it. Fibromyalgia is somatization of central processing disorder. Usually, but not always, brought about by traumatic experiences earlier in life. There is a high correlation between child traumatic experience and the future development of chronic pain syndromes, including fibromyalgia. That's not everybody. I'm not going to say it's across the board. It could be microtrauma, little t. It could be neglect. It could be stresses from growing up, expectations that people had for you when you were growing up. It could be a coach who was a horrible human being, but you didn't know that at the time. You were just in the middle of youth athletics. But all these little t traumas can add up. So what often happens is someone grows up in a challenging background or experience. They kind of get into their adulthood. They swallow it down into their gut, and they say, I'm stronger than this. I will do better than that. I don't need this to beat me. And they do well for a little while. And then a new trauma happens. A divorce, a bankruptcy, a physical trauma like a motor vehicle collision. Something happens, and now, snap. Now they're a fibromyalgia patient. Now they have fibromyalgia. The thermostat has been cranked all the way up on the pain center of the brain, such that small things that shouldn't be painful become exquisitely painful. It is physiologic. It's not in their head, but it is in their brain. They're not making it up, but it is real. Just as real as depression, just as real as PTSD, just as real as anything else we would call something like that. So they're not faking it. They're not opioid seeking necessarily. They're looking for some relief, and they're looking for someone who will sit down and listen to their story. All right, that said, let me pause a little bit and talk about how I diagnose someone's pain generator. So there's 4 categories I have, or 4 levels of evidence for pain generator. The most important is the story. What makes it better? What makes it worse? Bending, lifting, twisting, sitting, standing. Did heat help? Does ice help? Does a hot shower help? What hurts worse? Sitting in the car on a ride to Phoenix, or getting out of the car when you get there? Is there any weakness? Is there numbness, tingling? The story is by far and away the number 1. The second most important piece of evidence in my hands is a response to an injection. If I do an injection at a level and the patient gets substantially better for 3 hours, and then the injection doesn't help and the steroid doesn't kick in, for the patient, that's a negative injection. For me, that is a positive injection. That means we are barking up the right tree. We're heading in the right direction. Maybe the steroid isn't going to work, but at least we know that's where the pain generator is coming from. I encourage patients, do not go get back surgery if you've had injection after injection after injection and you've never even gotten a minute of relief. Now you're chasing hope, not a diagnosis. Third is the physical exam. I hate to say it, the physical exam is not as good as we think it is. It's full of all kinds of poor sensitivity and specificity. But it is at least somewhat helpful to your tool bag, and you should do it. But don't hold to it necessarily. Use it to rule in or rule out certain things. Is this SI joint or is this low back? Let me get you on the table, do a Faber's maneuver, do a Galensen's, do a fork and finger test and figure out if it's your SI joint. Do a sitting slump test. I don't like laying supine leg tests because they go, ah, that kills me. That doesn't help you. So you sit, hands behind the back, slump down, now you raise the leg. Then you take the foot and you go into extension and you see if you feel it, and then they look up. And a positive response, truly, truly positive, is ouch, more ouch, less ouch, because you're taking neural tension off of the meninges. Okay, so I said number 1 was historical, number 2 is response to an injection to figure out if that's the pain generator or not. Number 3 is your physical exam. And the last thing on the list, the bottom of the list, but it's still on the list, is imaging. Okay, the imaging is still on the list, but it's the least important. If a patient comes in with their MRI and they say, I have this, I have this, I have this, I have this. Okay. Yeah, you do. Cool. Let's talk about where your pain is actually coming from. Because you can have all that stuff on your MRI and have no pain. I took care of a gentleman whose spinal stenosis was so tight on the axial MRI you could not see daylight. If you looked at the MRI, you would say, how is this person walking? And they had 0 pain. And I've had beautiful MRIs, and patients were in horrid, horrid pain. The most extreme example I saw was a gentleman who had a large herniated disc at L4, L5. And he had had injection after injection after injection at L4, L5. And he was referred to see me. And when I said the word injection, he said, no, I've had injections. I'm done with injections. I want surgery. I said, well, hold on. Let's talk about that. How many injections have you had? 6. All at L405? Yes. Did any of them help even for a minute? Nope. All right, then let's time out for a second. Let's look at your MRI. He had a tiny little bulge at L2, L3. I put medicine at L2, L3. Pain went away. Do not use your MRI to make your diagnosis. Use your MRI to confirm what you're already thinking. Be a clinician, not an algorithmic driver. Talk to your patient, do an exam, get their story, figure out what you think it's going to be, and then look at the MRI and say, you know what, that does correlate. You have a herniated disc L4, L5, and it's migrating inferiorly, and it's hitting L5, and you're having zip leg down the leg. That's probably a sciatica or radiculopathy. You probably need to get that treated. That's when MRIs are great. MRIs are also great to rule out infection, rule out trauma, rule out tumor, rule out fracture. So it's not without validity, but it has almost no diagnostic validity for pain generation. And that's been shown study after study after study. Radiologists can never diagnose where someone's pain is coming from. They just can't. They can tell you what the MRI looks like, and that's it. All right, so I got lost. What was the last one? Emerging technologies. So I'm not going to go through all of them, but I do want to talk about some cool stuff. One of them is peripheral nerve stimulation. So peripheral nerve stimulation is this idea that in the body, if we block a nerve, we can stimulate the nerve, we can burn the nerve, we can freeze the nerve. So anywhere in the body that you have a nerve that is causing pain, we can treat that. So for example, in the knee, the nerve that goes to the knee is the genicular nerve. Even after you've had a knee replacement, we can block the genicular nerve. If you're someone who's not a surgical candidate and your knee is shot, we can still do this. We block the nerve outside of the joint. We're extra-articular. We're not injecting anything into the synovium. We're staying outside of it. We block it. If it does help for some period of time, awesome. If you've had a diagnostic block that's positive, we can now do something about that. We can do a radiofrequency ablation, although those are becoming less and less approved by insurance. We can freeze it with a procedure, or we can do a stimulator. So the stimulator is a device where we do a trial first, where we put the leads directly by the nerve, and then the representative programs the patient to see if it helps. And then if it does help, they can go to a permanent implant, and now they have relief of that. That can be done for the suprascapular nerve, for the shoulder. It can be done for the hip, the femoral and obturator nerve. It can be done for the back. So pretty much any nerve you have in the body, if you can block it, you can either burn it, stim it, or freeze it. Among that, there's lots of other cool stuff that's on the horizon. We've got vasovertebral nerve ablation for chronic discogenic pain. We've got spinal cord stimulation for low back, leg pain, and now diabetic neuropathy. It's indicated for diabetic neuropathy, and it works wonderfully, and it's actually on one of the 2 guidelines for diabetes epidemic. We have, like I said, peripheral nerve stimulator. We have minimally invasive surgical options. So if you have a patient who has spinal stenosis, and they're not a surgical candidate because they can't go under general anesthesia, there may be something that we can do to be able to treat that person. So even in our space, it's easy to default into the chronic opioid prescription for the patient who comes in for follow-up after follow-up after follow-up. But at the end of the day, there's more that you can do, even if it's a little bit more for that patient. Even if you reduce that opioid by a tiny, tiny amount every single time. The idea and the theory and the philosophy is that every single patient in my practice is on a chronic opioid wean schedule. It's just that some are going a whole lot longer than others, and some may not ever get there. So some of them might pass away before we get to 0. But nobody stays on chronic opioids forever and ever and ever. That's not an appropriate way to do medicine. All right.
I think there's going to be some questions. See, there's a question. It's always on that side of the room. I ain't going to stand up. I'm coming.
The first question I have is about complex regional pain syndrome, which I see people who tell me they have that, and what you do for that. And also the patients who don't want to reduce their opioid.
Yep, so what was the first condition?
Complex regional pain
Okay,
syndrome.
so complex regional pain syndrome is a diagnosis of upregulation of the sympathetic nervous system. There's criteria for diagnosing it. It's called the Budapest criteria. There's type 1 and type 2. There's causalgia, and then there's what used to be called reflex sympathetic dystrophy, RSD. So that is a diagnosis that can be diagnosed using criteria. You can do sympathetic stellate ganglion blocks to diagnose it as well. So if the patient has not had a diagnostic workup for CRPS or seen a specialist for CRPS in decades, it's probably worth coming back in to talk to them. The same as you would for someone who has RA, who hasn't seen a rheumatologist in 2 decades, because they say there's nothing in the sun recently for them. You say, well, maybe, but let's go talk to the specialist about that first and see if that's the case. So someone who comes in with the diagnosis CRPS, I want to confirm that diagnosis, just like I would for endometriosis, just as like what I would do for other conditions like rheumatoid arthritis or psoriatic arthritis. I want to get a confirmation from the specialist that says, yeah, they have that. And then from there, how do you treat? Yes, opioids take away the pain. They do. But there are other modalities that can help take away the pain as well. That's number 1. What do you do for the patient that does not want to reduce? That is a challenge for everyone. Some patients just don't want to reduce. And so you have to thread that needle very carefully. You have to give them the empowerment of you can, not you can't. You have to talk about the side effects of opioid, because very few people are giving the full gamut of what everything opioids do to you. Not just to your depression or addiction, tolerance, and dependency. That's not even what I'm talking about. I'm talking about what it does to bone health. It causes osteoporosis. How many people knew that? It causes hormonal dysfunction. It causes chronic liver dysfunction. There was a study done many years ago on patients who had been on a chronic opioid, one with acetaminophen and one without acetaminophen. And the rate of liver failure was the same for both groups. The acetaminophen wasn't the poison. The opioid was the poison. So you need to consent your patient to all of these things. But yes, it's a challenge. And it's getting the rapport, it's talking to them, it's establishing that relationship with them. You don't dive into childhood trauma on day one. But there's a certain level of relationship as the provider where you go, okay, I trust you, you trust me, let's sit and talk. Let's really sit and talk. And for me, because I have a busy day, I pick and choose my battles. So I'll say, okay, this patient right here, right now, I think we've clicked. I think we can have that conversation. And then I know I'm going to be stretched for the next half an hour to an hour. But I have basically the talk that I gave right now, except to the patient level.
Backing off the last question, which this could probably be a 3-hour discussion, but for patients, I work in a clinic that a lot of patients have been in that clinic for like 30 years, and a lot of them are on very high dose chronic opioids that have just been filled for 30 years. And again, you've kind of already answered this a little bit, but do you have any other tips or tricks in terms of getting them to buy into, hey, let's refer you out to pain management, hey, let's have this conversation about decreasing your opioids. You're still in pain, so this isn't actually treating the problem, really. And kind of any other pearls of wisdom, I guess. I don't know.
Yeah, I didn't go into opioids specifically as its own topic because that was the topic is non-opioid treatment. But opioids are a hormone in the body. We make opioids. We make endorphins and enkephalins. Those are opioid chemicals. If you give a body melatonin, what happens to the body? It makes less melatonin. If you give a body thyroid, it makes less thyroid. If you give a body insulin, it makes less insulin. If you give a body opioid, it makes less opioid. You will tolerate to whatever you give it. So if you go up on that med, it will feel great for a few months, and then it will stabilize. And then you go up, and it feels great, and then it stabilizes. So you be upfront with them. Yes, this is going to hurt you. I'm going to reduce you, and it will hurt for a little while. And then your body will adjust to it. And your 8 out of 10 pain on opioids would be 8 out of 10 pain off of opioids. It's always 8 out of 10. So am I supposed to give you a chemical that's dangerous to you and keep you at 8 out of 10? Or can we at least get you to 8 out of 10 off of opioids and not end up in a challenging position medically later?
One last question. I was wondering if you could studies on hormone replacement therapy for women with chronic pain, like fibromyalgia pain, and then replacing their hormones after menopause, if that helps, or during perimenopause.
So the question was about hormone replacement therapy in older females and whether or not it helps with pain. And I'm just going to make a short answer and say yes, probably yes. That works.